Good morning, friends. I will
Thanks, Devolina.
I will discuss about stable heart failure and the mortality benefits with HFrEF therapy in stable heart failure patients. So, the general interpretation among the clinically stable patient is that whenever we are dealing with the patient who are having heart failure but clinically stable, we think that all these patients are generally a low risk patient. But in reality, the undergoing process, the microbiological process which is undergoing with the patient who are having reduced heart failure is not like that. That continues to be in a fashion of deteriorating if we are not providing them a sufficient treatment. So generally what we generally avoid enhancing the treatment therapies in the patients who are stable and in whom we don't see any signs and symptoms. We are concerned about the side effect of the multiple drugs which we generally use for those patients who are having class A and class 4 symptoms. So should we consider them really stable patient? We will see in next slides that whether they are really stable or having some problem in that. Generally, heart failure is a progressive disorder because we can see there are the multiple episodes of decompensation during a chronic case of any heart failure. Whenever the patient is stabilizes for a time, then again in subsequent days, patient may have symptoms of acute decompensated heart failure. So in due course, what happens that the disease progression continues to be there, and at the end, the mortality is there. So, whenever we are considering a patient who are having heart failure, we should not consider them to be a truly stable patient. Though they are clinically stable, but the underlying structural and molecular abnormalities continues to progress. So that is very life-threatening and ultimately may land up into the sudden cardiac death. So what are the risks of mortality in stable heart failure? They have mild to moderate heart failure symptoms, and some patient may not have signs and symptoms of worsening heart failure at all. So in such patient, what we see that the chronic plasma troponin level are generally found to be increased, and it is because of there may be inflammation of cardiomyocytes. Some oxidative stress are there because of cell wall stretch, which may be associated with neurohormonal activation as a compensatory mechanism, and ultimately uh, so around 45% of the cardiovascular death is seen because of progressive and silent worsening of such patient, which remains unrecognized and untreated with proper medications. So if we consider class 2 HFrEF patients, the mortality is very high in such patient because we are, as per paradigm heart failure study, we have seen that the 6 out of 10 NYHA class 2 HFrEF patients, they die early at 27 months because, as we can see, the mortality is even more than 50% in such patients. So how can we reduce mortality in NYHA class 2 patients? So patient need to be that needs to be identified with uh, subtle changes so as to put those patients in HFrEF patient to a better journey. So we have to screen them by asking them, by giving them a leading question. So by whether they get tired easily while going upstairs, while doing any mild activity, or they are orthopening, are they are cutting their usual hobbies, are they are having any trouble in breathing, uh, are they are using elevators instead of stairs very frequently nowadays. So we need to put them on appropriate novel therapy, which we have gained from years of experience with various trials, right from COMET to we have many SWIFT trials, emphasis trials, and recently we do have paradigm heart failure trials. So using all these trials and the proper medication should be started for all those class 2 patients who don't have any kind of symptoms. So we should not wait for the patient to land up in class 3 and class 4 groups. So because the mortality keeps on increasing in such patients. So as we can see, the mortality in HFrEF patient remains high despite of introduction of therapy over last 20 years. We can see whenever we have started this remodeling therapy, the therapy which reduces mortality like ACE inhibitors or ARBs, beta blocker, which has maximum benefit, mineral MRA, we know spironolactone, ecliprinone, ARBs, and ivabradine. So despite advances in treatment of heart failure, we can see that still the mortality with 5-year survival rate is even around 50% suggest. So the current guidelines which we do have, this suggests that the patient with heart failure, even if symptoms are well controlled and stable, they require regular follow-up to ensure continued optimization of therapy and detect asymptomatic progression of heart failure. So as to start the therapy early. So ESC guideline recommend ARNI, that's sacubitril valsartan, as first line therapy instead of ACE inhibitor in all heart HFrEF patients. So use of ARNI is recommended as a replacement for ACE inhibitors in suitable patients who remain symptomatic on ACE inhibitors, beta blocker, MRA therapies. However, an ARNI may be considered as a first line therapy instead of ACE inhibitors. So even ACC guidelines recommend sacubitril valsartan as first-line therapy over ACE inhibitor for HFrEF patients. And recently, in ESC guideline also, which is there in 2022, they too have recommended it as a first-line therapy. So, which therapy we should prefer in NYHA class 2 patient to prevent mortality? Whether we should go for ACE inhibitors or ARB, or we should start early the sacubitril valsartan therapy. So as the guidelines are saying that we should start ARNI as early as possible in class 2 patients. And in subsequent slides, we will see that the advantages of sacubitril valsartan over current therapies. So it causes vasorelaxation, natriuresis, and diuresis. And ultimately, in molecular level, it inhibits cardiac fibrosis and cardiomyocyte hypertrophy. And at the same time, we ACE inhibitors, ARB, what we have valsartan, it suppresses vasoconstriction and sodium and water retention. Thereby, it ameliorates the congestive heart failure. So ultimately, it acts on underlying structural and molecular abnormalities which drive disease progression that is silent and life-threatening. So early what are the mortality benefits in NYHA class heart failure, wherein NYHA class 2 class. So majority of the patients belongs to NYHA class 2. So there, as we can see that the number of patients in each class, the class 2 patients were the highest one, and the mortality benefits are there. As we can see, it is 20% reduction, 20% reduction, 16, and 20% reduction. As we can see, the volume, the y-axis is showing the volume only, the numbers of the patients. The ARNI showed better efficacy in NYHA class 2 patient when we consider cardiovascular death and heart failure hospitalization. We can clearly see the hazard ratio is lesser for ARNI as compared to enalapril. And if you consider death from cardiovascular causes, in that also the sacubitril valsartan combination proves to be better than enalapril. There is 3 and 4 patients. So sacubitril valsartan improves survival time, though it is in the range of 1 to 2 years only, but definitely it improves the survival rate even after survival after age of 55 years and age after 65 years. In both the cases, 1 to 2 years of extended survival time is given by ERNI as per the guidelines. So, is there any evidence with ERNI impacting mortality in Indian HFrEF patient? So, we have to see that whether what are the effects of this particular drug in Indian scenario. So, Indian cohort, what Indian cohort says that the 83% HFs2, as we can see the data, that majority of the patients were having class 2 symptoms. So ERNI keeps Indian HFrEF patients alive as per the primary composite outcome. It shows that 11% reduction in risk of primary composite outcome in HFrEF patient with sacubitril valsartan as compared to enalapril. Considering the cardiovascular death, it 13% reduction in risk of cardiovascular death in HFrEF patient with ERNI as compared to enalapril, that has been shown in Indian cohort. And if we are going to consider all-cause mortality, there is 20% reduction in risk of all-cause mortality in HFrEF patient with ERNI as compared to enalapril. So all the data are showing that ERNI is better as compared to ACE inhibitors. And if you consider all the data of cohort and in relation to the global data, all the data are in equilibrium with the global data, that the treatment benefits of mortality were similar between Indian and global cohort. So considering the conclusion, we have to go with the guidelines that time is essential. We have to initiate ERNI as early as possible in class 2 patient so as to reduce the risk of cardiovascular death in heart failure hospitalization in Indian HFrEF patients. It reduces the risk of sudden cardiac death and it prolongs the survival time in HRF patients. So thank you, sir. This is all about the stable heart failure patient when we deal with HFrEF therapy and their mortality benefits.